Hey guys, Woodruff here. Tonight we have my final lecture, and it's kind of funny, I've had to do these last few lectures after finding out, we're going to a new textbook, which shouldn't be that different, but it's been a minute since I've updated my PowerPoint slides. I am doing all of these long lectures, but you'll see in the next coming months. I will be doing some, from here on out, I'm gonna include like my updated lectures, but I'm gonna split them up into small pieces to kind of make them a little bit more manageable, because most people don't want to sit and listen to me for 10, 15 minutes, let alone an hour or longer. But hopefully these lectures are helpful in the meantime. So they are definitely applicable to this semester, fall 2022, for those students that are maybe watching this at a time and being like, wait, is this what I'm supposed to be listening to? They are applicable. And even if you're in it for a future semester, and I'm talking to the future right here, this could still be very helpful, but always cross-reference it with anything new that I might have as well. Because stuff like a lot of this stuff is not really big changes, it's sometimes little minor changes, and I'll also try to include updates and just things that might stand out that are different when I make those new ones. But anyway, this is a long lecture, so if you're looking for short, sweet, simple content, look under Unit 4 for med-surg, and there's a whole lot of GIGU stuff, so feel free to peruse that if that's more your style. And from what I've heard recently is apparently I'm a lot easier to listen to at 2 times speed. So feel free to speed me up as you need to. So let's get in here and do this. So we finished up GI. So we're going to get into GU. So this is the urinary system. So we're going to talk about some more minor, I don't want to say minor inconveniences, but some minor problems, then get into some of the major urinary disorders. So just like there can be fecal incontinence, there can also be urinary incontinence. So urinary incontinence is similar to fecal incontinence, except that it's their urinary tract. They don't know when they need to go, or they have a sphincter problem where they can't hold it in. The bladder has too much pressure to hold. And it can be a lot of different reasons. I'll talk more about these on the next slide, but it might be due to confusion. It might be that they're unable to get out of bed, it's what we actually call a functional, where they're just physically not able to get up, so they cannot get there in time. There also is the possibility that infection can lead to incontinence, and there's medications that cause frequent urination as well. So there's more than one way to be incontinent. So the incontinence that I see most tested over, that we usually focus on, are stress incontinence. Later on you'll learn about reflex incontinence when you learn about spinal stuff, but functional is also a big one too. So stress incontinence is the one that, we talk about most often. And when we're talking about stress incontinence, so what we're talking about is that pretty much what's happening is some sort of excess pressure or stress from somewhere else leads to leaking or less strength in the urinary sphincter. So this could be like, you do a really deep or big cough and it causes you to, pee a little bit. You're laughing so hard that you pee, sneezing so hard that you pee, or heavy lifting can sometimes lead you to it. You see those videos and stuff of people that are heavy lifters that are like, oh my God, I peed my pants, or, stuff like that. There's also what's called urge incontinence, and this is like an overactive bladder. What that means is that you have too much of an urge to go. So your bladder's always go, 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 go. There's overflow, where you're just either, waiting too long, or your bladder's filling too much. And that what happens with overflow is the bladder's too full, so it just starts leaking a little bit to try to, get a little bit, since the bladder is so full, it's trying to get a little bit more out, just to kind of make more space for what's already still coming in. Reflex is just it's an incontinence that you lose the ability for your sphincter to fully close, things like that. You have an absent spinal reflex, so you don't have anything to keep that I don't want to say I guess it's like tightness or closure. Kind of think of like all the sphincters we've talked about between the GI and the GU system so far. But it's just a lack of ability to close because there's no signal from the brain spinal cord to keep it closed. And then there's functional, which we talked a little bit about, is that maybe they're so confused they don't even know when they need to go. They have a lack of mobility, or maybe they're somewhere where they can't get to a restroom, so they end up having to be incontinent. Like my son the other day was at school, and he went up to his teacher teacher and said, hey, I need to go to the bathroom. And they said, hold on a second, because they were by themselves outside and they were trying to find someone to go inside with him. But because he had lack of access to a bathroom, he ended up peeing in his pants. It's fun being a parent, I tell you. So diagnostic testing. So diagnostic testing is for urinary system, it's usually very minimal. We may look for other problems like a pelvic exam, may do a urinalysis to rule out infection. But a lot of what you're going to see is very consistent among urinary disorders is we do a test called a bladder scan. And what a bladder scan, this is something that you as the nurse can do. It is like an ultrasound, but it's not that fancy. I swear you can do it. If I can do it, you can do it. And it literally just tells you the volume of urine that's in the bladder. So you may wonder, how is this helpful for urinary incontinence? But it could definitely tell if they have an overfull bladder. We use this is a lot more helpful when we're talking about urinary retention, but also with incontinence, we want to know as well. And what we're usually looking for is how much is in the bladder, and then also after they pee, how much is left over. Because as a whole, after you urinate, there should be nothing in your bladder. You should fully empty. There might be a little bit in there, but there shouldn't be much. We'll talk about normals here in a little bit. But we might check this too. And really, we're just trying to figure out what is the cause of the incontinence. Because until we get to the bottom of the cause, we can't really help this patient. Because, again, if I'm sitting there and being like, oh, well, here, I'm going to make sure they have access, make sure they're less confused and all this stuff. But that's not their problem. Their problem is they have a spinal thing, or they have stress incontinence because they have a really weak sphincter. Like, none of that's going to help. So you're going to see on test questions, it's all about getting to the root cause of what is the issue with the incontinence, like what is the underlying factor, et cetera, that's leading to the incontinence, because we need to know that to know how to treat it, because there's different treatments for stress incontinence than there is for urge incontinence, than there is for the spinal reflex that's lost versus functional. So what does this patient look like? They look like they're leaking urine. Usually there is, you can see incontinence. They may be unable to recognize the need to urinate. Usually the first thing I do if I have a patient who's been incontinent is I ask them, hey, did you know you needed to go? Because that's an important question to know, like, are they aware of it? Or is it just happening and they're not even aware? It tells a lot about their general state too. They may be unable to get to the restroom in time. Sometimes people, they know they need to go and they start trying to go, but they can't get there in time. They have horrible urgency that's usually related to a UTI or infection. And you might also just notice there's redness, excoriation, or skin breakdown in their perineal area. So overall, my goal here is just like it was for bowel elimination. That was a priority for a lot of the disease processes. For urinary incontinence, having good urinary elimination is going to be key. So what I'm trying to do here is make sure, that they, again, getting to the root of the cause, we're figuring out what the cause is, and then we're going to try to get ahead or combat that. So we're going to do things to, if the bladder is, overactive or having a lot of contractions and things like that, we may give things like oxybutynin, which is anticholinergic. If they're having trouble where their sphincter's not relaxing, or they're having trouble with their sphincter in general, we might give them tamsulosin. If it's a male and they're having problems with their prostate, which is leading to incontinence, maybe they're getting urinary retention. And then sometimes when your bladder, again, it's over full, it's just kind of leaking out, we may give them things like finasteride. Now this, oxybutynin, you might possibly see on your exam. The two urinary meds we focus on the most, and we mostly focus on them with BPH, but you'll see tamsulosin can be used for almost every urinary disorder we talk about. But tamsulosin and finasteride are two meds I would 100% want to know if I were you. There are some surgical options and things that we can do, just again, depending on the cause. Weight loss can help, especially in, certain types of incontinence, like the stress incontinence. And the number one thing you can do for stress incontinence is going to be Kegels. And that's that, squeezing, contracting of the, of the urinary sphincter that we're going to do in order to strengthen it. Because if my problem is I'm sneezing, I'm coughing, and my sphincter is too weak, if I do Kegels, it's like going to the gym and working out, but for my, pelvic floor. And so effectively, it can strengthen my pelvic floor and help to have less incontinence. Having a good bladder regimen. So especially for those with functional incontinence, if I have like a really good routine for like functional, like the best thing I can do, take them to the bathroom every few hours, especially if they don't know when they need to go, like get them in a really good routine. Then also, making sure that they have a good bowel regimen as well. Now, this might not make sense, but if I have my bowels are full of crap, then it's going to create pressure and put pressure on all of my urinary, all parts of my urinary tract, and it can actually lead to a weaker sphincter. It can lead to more pressure, which can lead to a lot of bladder issues as well. Also, a good bowel regimen helps to prevent me from getting UTIs and things like that. And we'll talk about that when we get to UTIs. Then you definitely, we talked about spicy fatty acidic being very bad for GI disorders. For GU disorders or urinary disorders, I want to avoid things like caffeine, artificial sweeteners, citrus juices. I'll talk about more as we go along. All right, and then another priority is going to be maintaining skin integrity on these patients. So we're going to do things like timed voiding, like I mentioned, to prevent accidents, especially for functional, checking out their skin. We may use some incontinence collectors. We've really gotten away. Most people might say just put a Foley in them, but we really don't do that for many patients. Incontinence is not a proper indication for a Foley. Now, the only time it is if they had like stage 3 or stage 4 skin breakdown. We do things like, but there's external, I'm have pictures on the next slide, but there's external collection devices, things like that. Barrier creams are really key to kind of, it's all about that moisture, and then frequent repositioning just to keep them off of their skin. So there's a variety of new products that are out there. There's condom catheters, which can work great if sized well. And these are like an external, they fit on just like a condom for men, and they are super helpful to collect, in order to collect urine from men that maybe are unable, like maybe they're not as awake or they can't get to the bathroom in time. It is a good method. I mean, of course, always we would like to encourage them to use the urinal and stuff like that. And with some men, they have any, so it doesn't work all the time. So we do other things, like I've put like a pouch. It's kind of like having an ostomy pouch, but around their penis, and you put some really good, what is it called, like not ChloraPrep, skin prep, which is like sticky stuff, and you can get a pouch on there. So sometimes if they have an any and they can't fit a condom cap, that works. You're definitely going to see these two things in blue, also known as a pure wick, and they work great for patients that have thick thighs, and that can keep their legs closed. People that are moving around a lot, they are not very helpful for. These are for women. They can be used for men too with innies. I've seen them be used for men with innies. But effectively, the thought process is the patient's peeing into this white area, and this is attached to suction, and it literally sucks the urine out as they urinate. And so there's some that work better than others. And when I was working this summer, they were taught at another hospital, they were talking about how they have like new ones that are better. Like the regular pure wicks only have one hole for suction to go up into. And so sometimes, depending on positioning, there can be a lot of leakage, or they don't always work the best. But they have a new one that has like a bunch of holes. It's called like a 360 or something, and it's supposed to help to like get suction and stuff better. Keep in mind with these devices, and these are like chuck pads for people to pee on, and then there's diapers too. You're really not going to see diapers a lot in the hospital. They've moved away because it really just keeps moisture in. It's not very helpful. But as a whole, with all these devices, they need to be changed regularly. So we change condom caths usually every shift, or at least every 24 hours. We change pure wicks every shift, at least where I work. You don't want to keep this down there, and you want to, again, be assessing their skin and looking closely for problems. So let's talk about urinary retention. So this is where people are so this is kind of like constipation, but for the urinary system. So it's a lot more serious though, because with urinary retention, you only have so much space to store urine in your bladder. And so eventually what can happen is you can end up getting bladder rupture, which is very severe and can lead to peritonitis and a lot of other issues. So acute urinary retention is an emergency. It's where you're unable to urinate at all, whereas some people have a chronic inability to fully empty their bladder. So they're emptying it, but they still have a good amount left in. Causes can be there's an obstruction, a weak bladder muscle, it can be prostate issues, it can be infection. Some people are going to be more at risk than others. But this is literally like, you can see it here. See how big this bladder is. The bladder should never be palpable, unless you have a full bladder. That's why, if you ever are palpating someone's abdomen and you want to try to palpate their bladder, please ask if they have to pee first, because it's so mean to push on someone's bladder like they're trying to be nice and let you get their assessment done. And then they really have to pee and they're trying to be nice to you. And then you push on their bladder and they end up becoming incontinent or just being like, so yes, definitely speaking from experience, you do not want to push on someone's bladder without asking. But there's a lot of possible causes. Neurogenic, we talked about a neurogenic bladder with diabetes, things like that too. So diagnostic testing I'm going to do for this patient is the same, like I mentioned, for urinary incontinence, that we're going to do a pelvic exam, kind of see what's going on, make sure there's not an infection. What do you call it? Because I should say, like, infection and urinary retention go hand in hand. Anyone who's having urinary retention is at higher risk for getting a UTI. So we're going to be concerned about, anytime you hear like urinary retention, you hear about prostate issues, which leads to urinary retention. You hear about neurogenic bladder. These should all cue you, there's urine just chilling in the bladder. That's always like high risk for infection. So when we get to UTI, we'll talk about this. We never like stasis of the urine. So then the really important diagnostic to do is a bladder scan, because this is going to tell us exactly how much is in the patient. And then for acute, it's going to tell us, hey, their bladder, like, I've had 999 up, on that screen. I'm saying like there's almost 1,000 in the bladder. To give you a little bit of a scale or a measure to look by, like you or me, we probably have to go to the bathroom when we have about 200 or 300 in our bladder. That's like, and we may even get like an urge to do before then, but most of us are not going around with 1,000 milliliters in our bladder. If we are, man, we got some, we're some troopers. Now, nurses do hold their bladders more than maybe other professions do, so we might be able to hold a little bit more, but that's really extreme. So we want to see how much is in there. But then for someone who has chronic urinary retention, what we can look at is that post PVR or post void residual. So you want to think about how much is supposed to be in the bladder. And again, like I said, usually after you empty your bladder, there should be nothing. But if someone has chronic urinary retention, what I would notice is that I would do this right after they urinated. They would maybe go in the urinal, however they go, and I'd scan their bladder, and then I'd be looking for how much is left. And I believe I have it in a couple slides, but I believe it's like greater than 100 is abnormal after you urinate. This patient, depending on the cause, may have a variety of symptoms, may have hesitancy or inability to get started with their stream, a weak urinary stream, they might have frequent small voids, abdominal pressure, or in general, just say, I don't think I need to go, or I can't go. So having acute urinary retention is an emergency. So in acute urinary retention, we usually, like if a patient comes in, they're agitated, bladder's distended, they cannot urinate, then I am going to be going straight for either a straight cath or Foley catheter, just depending on what the physician wants. But we need to acutely relieve I was going to say that large, I'm going to keep going before I say stuff that, I'm going to regret later. But they have that full bladder that we need to relieve. And so think of it like, there's an obstruction that we have to relieve. And so we're going to definitely need to, get them catheterized as soon as possible if they're unable to go on their own. For people that have chronic urinary retention, we may do timed voiding, which is kind of like where we take them to the bathroom every so many hours, or double voiding, which means we tell them to void and then tell them to go again. Supporting urination, which means like creating an environment that's going to be very helpful and conducive to them using the restroom. Most people are not used to people sitting around watching them urinate, so the best, like most comfortable environment that you can create for this patient, try to do so. Sometimes doing things like even turning on running water and things like that can help too. I talked about checking the post void residual on a schedule, and anything greater than 100 is considered abnormal. There are medications. Again, here you go. I told you you'd see it again. Tamsulosin. You definitely want to know that one. It can also help to relax if there's just like a very tightly closed sphincter. And then if this prostate is what's getting in the way, causing the retention, work on that. They may need a pelvic reconstruction possibly. And then again, treating the cause, like if it's diabetes or otherwise, managing that well. So general education for these patients, we want them to drink small quantities of water throughout the day. And the reason for that is you may think like, oh, don't we want them to stay hydrated? Absolutely. But if their bladder, either there's a sphincter issue, a bladder issue, what's going on, depending, is that if they're unable to regularly fully empty their bladder, or they're acutely retaining, we don't want to put so much fluid on their bladder that then it's going to be like an issue where their bladder could rupture. So small quantities throughout the day versus like large quantities at one time. So we do want them to have adequate intake, but we want them to spread it throughout the day so they don't overwhelm their bladder. Things like, we talked about some irritants and stuff like that. We want to avoid excess alcohol intake. I talked about bladder training. And then if this is chronic and there's no other way, fix around it, they may need training how to intermittent catheterize themselves. So speaking of catheters, like I mentioned before, it's not like what it used to be when I first started in healthcare where everyone got a Foley catheter. Now there are only specific indications for it and for good reasons because catheter-associated urinary tract infections have become a little too common and popular. So what we're going to look at is for reasons is going to be acute urinary retention. I mentioned if they have incredible skin breakdown like stage 3, stage 4 pressure ulcers. And I was actually reading an article today in a journal that was talking about that pressure injuries can cost, like a stage 1, like a minor one might cost like $50,000 in costs, but a stage 3 or stage 4 can cost up to $150,000 just for the treatment for the pressure ulcer alone. So I'm just saying here, pretty crazy stuff. Anyway, we want to do another reason we might is, like being an ICU nurse, we do insert them for accurate measurement. If I have a patient in renal failure, patient with really, in shock and having a lot of issues, I need to accurately be able to measure every hour what's coming out of that patient. So we do put them in sometimes for that. Terminal illness, so for comfort of the patient that's at end of life, and certain surgical procedures. So there is like urology Foleys, if the patient has something, a different anatomy or something else going on. So there's a variety of urinary catheters. You don't need to know about too many of these. You will need to know what an intermittent cath is, an indwelling catheter. Well, I guess you do need to know about all of these, so I'm not going to lie. But not necessarily it's not about knowing like the type. We're not going to show you a picture and be like, what kind of catheter is this? At least I don't know yet, but I would highly doubt that we would do that. But you definitely want to know about why we have these different catheters. So intermittent is like an in and out. It means it's not going to stay in there forever. It's usually a little bit of a smaller size. We'll talk about it on the next slide. Oh, excuse me, these late night fun things. So yes, so indwelling catheters, these are the ones that are that stay in, like they're what you think of when you think of a Foley catheter. And they would look like here on D, where there's a balloon and stuff like that as well. Then there's what's called a Coude catheter. That's what this E is. And Coude, think C is for curved. It has a curved tip, and this curved tip actually helps to get around the prostate. So Coude is for men with prostate issues. You can generally, you can't guarantee, but most men over 60, especially over 70, have some sort of prostate issue. And so a lot of times it's great to start with a Coude, but most of the time you're going to start with a normal one, and then you hit some of the obstruction that is the prostate, and then end up switching to a Coude. I'm not saying that every older man patient has to have one, but I'm just saying a lot of times you're going to end up going that way. And then a 3-way catheter, this is used for bladder irrigation. So we'll talk about this when we talk about prostate surgery and the TURP. So intermittent catheterization, this is like an in and out cath, like I mentioned, where we stick the catheter in, drain the bladder, and then pull it out. So this is great for patients that are maybe having like an acute problem or change, but should be able to urinate on their own, or sometimes people use it long-term for people that are just not able to urinate on their own, so they don't have to have a catheter. It requires training. It really should be a sterile procedure, but I've seen some facilities that say that it's not fully sterile. So and people can go home and do this by themselves, but usually we want it to be as clean as possible. There's indwelling Foley catheters. Um, and these are obviously what you guys are going to see most of the time. They just have one port here, and that we inflate the balloon and stuff with, and then this is where the drainage port connects. Usually they're 16, 18 French is about what you're going to see most of the time in the hospital, but you can see different sizes, obviously for different reasons. Coude tip, like I mentioned, helps to get through the prostate, especially when it's enlarged or they're having issues with their prostate. In general, with men, when you're catheterizing them, you definitely want to sit their penis, straight up and try to go like down versus doing strange angles and things like that. But sometimes, having a catheter that's going to more easily get around that prostate is going to be the only way that you're going to get in. Like I mentioned, we'll talk more about three-way, but a three-way has it's same as like an indwelling catheter, except it has an extra port that connects to irrigation, so I can irrigate. So this will be helpful when we talk about TURP procedure and how we have to flush out the bladder. So it'll make more sense when we get to it here soon. So what is overall my role as a nurse who's taking care of a patient who has a Foley catheter or an indwelling catheter? So I don't want to break the seal. So this red seal here, I mean, every hospital has different policies, but in general, I don't want to break this seal because this is a tamper seal. So this tells me if it's off, it means that at any point there could have been a disconnect in that circuit. This patient could be much higher risk for catheter-associated infection. So I actually have we have a policy at my facility, or a general procedure we follow, that if the tamper seal is not intact, we usually end up, unless there's some reason that we cannot, we'll take this catheter out and put a new one in that has a tamper seal just to reduce it. And I used to think like, man, putting a new catheter in, there's such a high risk of infection, but there's actually a higher risk keeping one that has a tamper seal that's not intact than otherwise. So I actually chart every shift that I checked that tamper seal and that it's intact. We want to keep the bag below the level of the bladder. I really don't want urine to reflux back into the bladder because that can lead to a higher chance of infection. So what I mean is that I always want to keep things running downhill. I don't want to hold that bag above the patient ever, it should always be below the level of the bladder. I need to do really good perineal catheter care, cleaning around that tube. Usually most hospitals have a policy to do that CHG baths or the CHG cleaning of the catheter, if nothing else. Anchoring devices, that's what this is here in this picture. And so an anchoring device is effectively to keep things where it's supposed to be. It allows for good drainage, so there's less backflow, and helps to keep it in place. It's obviously inflated with a balloon, so it's not that you have to have the anchoring device, because a lot of people, you'll go to the hospital and you find that they don't, but they should have it. It helps definitely keep things where they're supposed to be, and then also get good drainage. And then, my biggest role, you're going to find that most hospitals now have what's called a SDO, or standing delegated order, where if I as the nurse am like looking at a patient, they have no reason to still have that Foley, I actually can take it out without a doctor's order because of a standing delegated order if they meet certain criteria. Now, I mean, generally most of the time we run things by the physician just to be extra safe, but just know that you do have, there are some standing delegated orders, so know your hospital's policies and stuff like that, because we definitely want to try to take these out as soon as possible. So I think that there's supposed to be some words here, and I think it's supposed to say suprapubic catheter based on this picture. So this is a suprapubic catheter, and what this is it allows for drainage directly from the bladder. And this is great for patients who are spinal injuries, are going to need a long-term catheter, other things are just not effective, etc. It can also be for people that have like bladder cancer, other types of GI and other cancers that might require something, or maybe someone who has some anatomical defect, etc. So it's similar care to the Foley. except, usually it's, we maintain the gravity drainage. We need to reposition it. Sometimes it's talking about milking of tube to prevent clogs. I have never had to milk one of these tubes, but just know that it is possible, and sometimes it might be a little positional compared to a Foley, just based on where it's at. But definitely keep a close eye on that and be looking for infection and other issues. Aside from a suprapubic, there's also what's known as a urinary diversion. So similar, like I mentioned, if there's, if someone's having chronic urinary infections, there's trauma, there's strictures or narrowing of the urinary tubes and stuff that we'll talk about, or if there's some sort of genetic malformation or cancer, a lot of times patients can end up with a urinary diversion. And just like the name suggests, it's a diversion or a way for urine to get out of your body aside from the normal means. So there's a couple different types. Just think of this kind of like ostomies, but for urine. So the first one's what's called an ileal conduit. And what this is that they take part of the bowel to create a stoma. That's why it's called an ileal, because it's from the ileum in the bowel. They create a stoma, and there's an external appliance, kind of like in that last picture on this last page. Oh, I'm so sorry. Oh, it's one of those nights. What do you call it? But I promise I'm not bored. I'm always excited to be here. I would say like 87.93% of the time. So even though this is not my favorite topic, but it's better than some, so I'll take it. It's better than ears and eyes. So they have an external appliance, and again, they're literally peeing in a bag. There's a stoma, so you have to keep an eye on the stoma. You need to keep an eye on their skin. You're going to be watching it really closely. There's also continent pouches that they can have, just like they can have the Coke pouch for their stool and stuff like that. They can also have continent pouches where there's like an internal pouch that they catheterize, and they're going to do that every 4 to 6 hours. And that same, I didn't talk about this, but with intermittent caths, we usually do them every 4 to 6 hours. Same thing, they use part of the bowel. And you may be wondering, why are they using part of the bowel to create these things? And the reason is because the urinary tract is a lot more narrow and more friable. So they find that the bowel has a lot more stability as a tissue. So that's why so they literally cut out part of your bowel and use it to make a diversion for your urinary tract. The nice thing about the continent pouches, of course, is that there's no leaking. So there's also a cutaneous ureterostomy. So here's the thing about the ureters. They're an incredibly narrow tube. They can have these two stomas with this ureterostomy, but there's a huge risk of stenosis, strictures, because it's such a small stoma. So a lot of times they need multiple dilations to keep them patent. So this is definitely not something, I've never seen someone with a ureterostomy ever, but it's always possible that you could find a patient with them. Last but not least, the last diversion would be what's known as a nephrostomy. Now, this is something straight from the kidneys. And so we kind of had like suprapubic is at the bladder. And then as we're moving up, we have the ileal conduits, the continent pouches, and then we get up into the ureterostomies. And now we're all the way up at the kidneys at a nephrostomy. This is a catheter inserted into the pelvis of the kidney of either one or both kidneys, I should say. There's no need for surgery with these. It's what do you call it? A procedure. I want to say they usually do it in IR, but I could be completely lying to you there. There's high risk for infection because there's something in you that's not yours. And then also because you have a device in your kidneys, it can lead for accumulation of stones. They have to be changed monthly. So this is not usually something that's used long-term. It's usually used short-term. So a lot of the care and stuff that I'm doing here is going to be very similar to what we did for GI. We want to make sure, especially if they have a pouch or a stoma, that they're being seen by a wound care ostomy nurse. We want to make sure that we help them with the emotional transition, especially if they have that stoma, things on the outside. It's the same like it was for ostomies, where we want them to be able to look at their stoma, care for it, etc. And that's a good sign that they're healing and getting recovered. Monitor their intake and output closely, and we're going to encourage them to have fluids to flush and keep everything patent. They need to learn how to care from it, good hand hygiene and other hygiene, and overall meticulous skin care. All right, so we have survived through the kind of basics starting into the urinary tract. So now we're going to get into the main disorders. So the main disorders that we talk about when it comes to what do you call it? Urinary disorders is that we talk about UTIs and we talk about BPH, and I feel like I'm forgetting about one. And kidney stones, that's it. Your UTIs, kidney stones, BPH. So those are your three big hitters that you're going to have on this exam. So you definitely want to pay close attention to these. So anyway, let's start with UTIs. So this is something you're going to see very commonly no matter where you work, whether you work with males or females, even though it is more common in females. But you're going to see a UTI sometime in your career, most likely. Kids or adults, UTIs happen. So it is the most common bacterial infection that a woman can get, and usually it's caused by E. coli. And if you, E. coli is usually in the stool, so you may be wondering, why is this happening? But you have to think about, where a female's urinary tract is located. It's very close to where their anus is or where stool comes out. And as a result of improper hygiene and just location, it's more likely for stool to get in the urinary tract, which leads to a UTI. So there's usually pretty good defense mechanisms and things in place to prevent UTIs, but when those defense mechanisms are broken down, that's when the tract can become infected. So it could be there's a change in pH, like when women use feminine hygiene products and stuff like that and want to make their hoo-ha smell like rainbow gold. And it usually doesn't turn out too well. I'll talk about that. There also is mechanical malfunction. So if you have a sphincter issue where your plug isn't closing, it could cause some issues there. And then, of course, like I mentioned, hygiene, just user malfunction. So the risk factors for urinary tract infections, should say urinary tract infection risk factors, is going to be urinary retention. Like I mentioned already, like stasis of the urine is one of the worst things that can lead to infection. Just kind of like, of course, I haven't brought up the cardiovascular system that much so far. I always got to tie it back in. I've talked before about how, if blood is sitting still, you're at risk for blood clots. So think the same thing. Urine sitting still, I'm at risk for infection. Having a device like a catheter is going to put you at risk. Like I mentioned, poor hygiene. So a lot of people do not wipe front to back, whether because of their body habitus or just bad, habits, things like that. So poor hygiene is an issue. Feminine hygiene products, like I said, the big thing today is to make yourself smell just like butterflies, rainbows, and daisies. And while it may seem like that is total priority over maintaining pH of your urinary system, everything that us women have down in our hoo-has, and that is the official term, by the way, is exactly what it needs to be. Like, it is its own ecosystem down there, and that's the best way I can explain it. But we're constantly messing with it. We think we need all these special cleaning products and all this other stuff, not just to make it smell nice, but we think we have to clean it like crazy. We think that like the best thing to do. And I'm here to tell you, like, and I'm not sitting here advocating for this because I'm not saying that I perfectly follow this, but I've actually listened to some really interesting stuff from some gynecologists and otherwise that say you're really not even supposed to put soap down there. Like, you can let soap kind of run through there, but it's its own ecosystem. It cleans itself. Just water, rinse it off and stuff like that. And that you're not supposed to be scrubbing or getting really deep and crazy cleaning in there. And most women do. Like, most women, we have this feeling like, oh, I got to clean it. It's really dirty, etc. down there. And a lot of times what we're doing is actually getting rid of the good bacteria that's down there. So it's kind of like how in the GI tract where there's good bacteria. Now, I'm not sitting here advocating for one or the other, and to always talk to your doctor before you do this. I am just merely educating you on the fact that what we probably think is what we need to get clean may be different than what we actually think. So there's a difference between feeling clean and what actually is helping your body, etc. So in general, there's just a ton of products and there's a ton of, misinformation out there about what to do to actually clean yourself. But old habits die hard. Diabetes. So anytime you see a patient with diabetes, they're always going to be more at risk for infection, but especially UTIs, because remember, diabetics, they have an excess of sugar. And when you have too much of something, where does your body get rid of it? Through your urine a lot of the times, because that's your one of your filters that gets rid of excess of anything that's in your body. So if I have a bunch of glucose chilling in my urinary tract, bacteria love glucose. They're sitting there like, hey, we hear there's some glucose chilling in this urinary tract, and so they're going to be going after it. So definitely those are some of those key risk factors. So let's talk about some terminology. So, when we talk about the urinary tract, we have your urethra, which is the exit to the outside. We have your bladder, we have your ureters, and then we have your kidneys. So you can get an infection of any part of this. So if it's, if it's the all the way, in your bladder, urethra, you have urethritis, or you have cystitis. So keep in mind on your exam that you could have any of these. You could have, it says, hey, a patient has a UTI. Hey, a patient has cystitis. Hey, a patient has urethritis. So, you definitely would pay attention. A lot of those are pretty similar. Most of the time when we're talking about a UTI, we're usually talking about a lower UTI, but there are differences there. I'll talk about it here in a second. But you definitely need to be able to differentiate, okay, what happens when they have a bladder infection versus as we start climbing up, there's different complications, different symptoms. So there is urethritis, which is where your urethra or the tubes that connect from the kidneys to the bladder, they get inflamed, infected. And then the most severe thing that can happen, or the biggest complication from UTIs, is going to be a pyelonephritis or a kidney infection. And this can lead to urosepsis, because once things get into the kidneys, they can get into the bloodstream, and you can have a lot of problems. So what does a patient look like that has a UTI? And so when I'm talking about a patient that has a UTI, I'm really talking about a lower UTI here. So someone who has like a bladder infection, cystitis, urethritis, stuff like that. So usually the things they're going to complain about are painful urination. I would say the top symptoms we usually get complaints about are the frequency and urgency. They could also have blood in their urine. They could have trouble starting their stream or have leaking, feel like a feeling of incomplete emptying or incontinence as well. So this is where I told you want to be able to differentiate. So that's a lower urinary tract infection. Once we start getting into an upper urinary tract infection, they're going to have the same symptoms of the lower, plus because the kidneys are involved, they can have flank pain. And remember, your flank is just like in this picture, here in your back area, because of where the kidneys are located. They're in the posterior region of your abdominal cavity. Okay, so I just want to make sure it sounded weird. They also tend to have more systemic symptoms of infection, like chills and fever. Whereas with a lower UTI, you're not going to see as like the real high-grade fevers and things like that, or fever much at all with a lower UTI. There's also going to possibly be more systemic symptoms like fatigue and loss of appetite. UTI also presents different in the older adult. Believe it or not, I think to find this picture, I think I just Googled, I think I just Googled confused older adult, and this is what came up. So I'm not doing this out of malice. I just don't know why Google does what it does. So older patients in general present differently with all disease processes, but especially infection. So with a UTI, they can commonly have no urinary symptoms. All they have may be with some generalized abdominal pain, confusion, delirium, and they can have general weakness and fatigue, things like that as well. So look out or think outside the box when you have an older patient, especially if they're acting confused. It can be a sign that they have an infection. So there is some important diagnostic tests that we want to do for someone with a UTI. We want to look inside their urine and see, is there bacteria present? Are there white blood cells? Obviously there'll be bacteria because there's an infection, white blood cells because they're coming to the rescue. And then there's also presence of a couple particles in there that are just linked to infection. One is called leukocyte esterase and the other one are nitrates. So if those are present, it's usually a sign of an infection. The most helpful test, we're all going to get a urinalysis on everybody because that's the first start. And sometimes just on a urinalysis alone, we can tell a lot. But usually they're also going to get a culture and sensitivity. And this is particularly important because if you remember back when we learned about pneumonia, a culture tells me what's growing. And if I know what's growing, I know how to most effectively treat it. But even what's more helpful, if I get a culture and sensitivity, the sensitivity tells me for this particular bacteria, this E. coli that is in this person today, these are the antibiotics that it's going to be most sensitive to, or this is the best treatment for it. And not just like pretty much because every E. coli is a little different. Some can be a little resistant, etc. So we might also potentially, especially if there is getting to be kidney involvement, we might get an ultrasound of the kidneys to see what's going on, or of the bladder. this seems like it's in the wrong place. Maybe me. Oh, no, it's not. No, yeah, no. I was sitting here, I was like, why did I have this here? But yeah, I think it's because I had another slide in previous semesters that I took out. That was just how to collect a sterile urinary specimen. Just know if they have a Foley, there's these ports on them that we draw the specimen from. You want to make sure to clean that port before you get your specimen. You don't want to just take it from the bag, especially if they've had that bag for a while, because it could be contaminated. We want to try to take it as much from the sources we can. We otherwise, if they didn't have a Foley, which again most patients don't have Foleys, we may have to get what's called a clean catch specimen, and generally we like them to pee a little, to wipe, of course, and clean and stuff like that. Pee a little bit, and then put the cup under, because the first little bit that you pee out might have some bacteria in it, but doesn't necessarily mean that you have a UTI. All right, so we talked about the biggest complication with the UTI being kidney infection or a upper urinary tract infection, and that's what's known as pyelonephritis. It usually results from a lower UTI, but there are other possible causes. It can spread from other places, and it's usually bacterial. I told you already they have the really bad flank tenderness. They can have the more severe symptoms like some of the GI stuff, the fever, the other urinary symptoms. And it's going to be diagnosed the same, but the only difference here is we may do some like blood cultures to see if they are systemically spreading their infection, but also we're going to look for something a little different in their urinalysis. We're going to see something specific as what are known as casts, just like a cast, like if you had a fracture, but they're not actually casts. Don't get me wrong that I'm saying that it has to do with fracture. I just mean in case you're not sure of the word I'm saying the word cast, like a cast you would have for a fracture. But what this actually is tissue from the kidneys. And so if this is pregnant, oh my goodness gracious. All right, it's time for bed. If this is present, then it's a sign that the kidneys are starting to break down, and it's a sign that there's kidney involvement effectively. So when someone has a lower UTI, they should not have casts because there's nothing going on in the kidneys. It's all a bladder infection. But once it gets up to the kidneys or an upper UTI, then they can start to have kidney breakdown. Overall, my goals are to manage infection, so aseptic technique with urination and any devices they have, regular personal hygiene, hand hygiene, and antibiotics are going to be key. So speaking of antibiotics, there are, there's different, there's a variety of treatments that are used. I'm going to talk about two medications specifically that are most commonly preferred for this. And this is what's preferred right now because there's lots of antibiotics becoming resistant because UTIs are so common. So the first one, I'm going to call it by its brand name, but you need to know it by its generic name. But I'm going to call it Bactrim. Keep in mind, watch the skin. It is a sulfa product. So assess an allergy to sulfa, and they can have rashes and things with that. So look for that. And then there's also macrobid, and this can affect the liver and kidney. I guess if your liver, okay, I'm gonna make a really bad joke real quick, that if your liver and kidney were dating, they would be the Lidney. Like that would be like their dating name or their relationship name would be Lidney. So I think my brain is on an efficiency kick and sometimes puts words together that I'm trying to say too fast, too quick. But the Lidney function, aka liver and kidney function, and yes, I'm laughing at myself because I sometimes crack myself up because I'm so strange. But anyway, we're also going to watch out with macrobid for peripheral neuropathy, and just know that this medication can turn urine brown. A lot of the sulfa meds as well, they can turn stuff orange. So I'm just kind of recognizing that. So UTIs antibiotics in general, the general stuff that you always want to consider for all antibiotics is always assess for allergies no matter what, for all meds, of course, but especially for antibiotics because there's just higher risk of allergic reaction. Always check kidney function because all of these, yes, I know you're thinking, well, it's a kidney infection. Of course, I'm going to check kidney function. But I mean, for all antibiotics, you always want to check kidney function because they can, make your kidney function worse. There's lots of drug interactions, so definitely kind of keep that in mind, especially if you're hanging two things at the same time. Watch out for superinfection like C. diff. Now you know all about it. And then the most common side effect of all antibiotics is GI side effects. So usually if it's oral, we recommend them take it with food for minimal side effects. IV, it helps to take it with food, but it's not as noticeable as with the oral. So yes. Other priorities I have for UTI is managing their symptoms. So I want to relieve any discomfort that they're having. There is a phenazopyridine, and this is like azo. It helps to relieve, I have it on the next slide. It helps to relieve discomfort and pain associated with that frequency, urgency, stuff like that. Heat packs to see there I did it again, heat packs to the lower back, abdomen, and stuff like, or the back in general, and then the lower abdomen, I should say, can help, to help with some of the discomfort, irritation that they have. And then, of course, we want them to urinate well. So, we want to encourage fluids with these patients, safety precautions, because they're probably going to have to go to the bathroom. Remember, they have that urgency and frequency. And then regular assessment. I really know this patient's doing better. An infection getting better. I mean, I can look at a white blood cell count and be like, "Ooh, yay, their white blood cell count's better." I can look at their urine and see that things are clearing up. But how are they feeling? What are their symptoms? Is that frequency, urgency, painful urination, is that getting better? So that other one, that phenazopyridine, also known as azo, helps with urgency and frequency, but it can turn your urine orange. So there's lots of urine color changing things. I would definitely kind of maybe make some note cards or kind of take note of that. Overall education, they need to finish all antibiotics. We want to help patients to avoid increasing their risk for urinary tract infections. So education really here is key. It's a lot of the stuff we already talked about. So people should empty their bladder regularly and completely. Oh, and I don't think I ever really went into this. So I talked about it like minorly, but in the beginning, like, why are women more at risk? So women are more at risk a lot because of anatomy. We have a shorter urinary tract, and we also, again, there's the fact that our pee hole is very close to our anus. And so as a result of that, there's just a higher chance for bacteria and stuff spreading. And so it's all about anatomy. And then again, there's also the like personal hygiene products and stuff like that as well. But anyway, so and the reason the shorter urinary tract matters is because it's a lot easier for bacteria to get to a place that they can cause a lot of heck. That's really great English. Great job. So yeah, I'm talking to myself. It's very easy for them to get into trouble in your bladder. So I hope that in these moments when I'm half laughing, half, wondering if I should still exist, that you're laughing with me at my craziness. So let's get back on track here about where I was talking about like who's at risk. So like we talked about women, diabetics, people with urinary stasis and everything are more at risk. So we want to kind of combat these factors. So we want people to empty their bladder regularly and completely. And so what that means is that we don't want people to hold it. So especially like us nurses, we need to be better at emptying our bladders on a regular basis. And we empty them, making sure that we're emptying fully. And so like if I'm someone who has like chronic urinary retention, like I mentioned, doing that double voiding, making sure they're getting all their urine out. Emptying the bladder before and after sexual intercourse to help to reduce the amount of bacteria and other stuff when all the bumping and grinding's going on, to decrease your risk of getting an infection there. Regular bowel evacuation. Like I mentioned, if I have a bunch of stool sitting in my rectal pouch, it's a lot easier for that E. coli to crawl on over to my urinary tract. So regular bowel movements are key. It also puts pressure on your urinary tract, which could lead to retention and other things like we talked about. Wiping front to back is so key for these patients, making sure that we're getting good hygiene. Water and fluids are generally good for most urinary tract disorders. Remember, the only, caveat there is for urinary retention and for BPH, which we haven't talked about yet, but we will. I like them to spread their water throughout the day. But for everyone that's urinary, we like fluids. Fluids are good. We also want to avoid feminine hygiene products. And people always ask this, does that include tampons? I mean, if they're scented or have something strange in them, yes. But if they're just regular tampons, it should be fine. We just don't want to do anything to alter the pH in that area. We also want to encourage cranberry tablets, cranberry juice. Cranberry is very urinary friendly. So a lot of people mix this up. Citrus, bad for urinary. Cranberry, good for urinary. So these are two different things. Cranberry is not a citrus juice. You think citrus juice, you think things like lemon. But bladder irritants, caffeine, alcohol, citrus juices, chocolate, and spicy food. Like, here we go again. Like, every time you think that it can't get worse, it gets worse. So now let's talk about kidney stones. So kidney stones also have a lot of names. On an exam, you could see urinary tract calculi. You could see kidney stones. You could see nephrolithiasis. All of these mean the same thing. There are stones in the kidneys. This is more common in men, and it's more common during summer months. It has to do with dehydration. But there are different types of stones, and you don't have to know crazy in depth about the different types of stones, except in general what they are. So there's calcium oxalate stones, which are associated with like too much intake of tea and fruit juices, or too much sodium, which we'll talk about. There's also uric acid stones. These are some of the most common types of, the calcium oxalate is probably one of the most common. And then you also can have the uric acid stones. So we definitely want to know kind of what are these stones made of, because a lot of times, regardless of what I do to treat someone's kidney stones, if they are taking in too much of something that is causing them to make more stones, I can only help so far. Other risk factors, like I mentioned, dehydration. So if there is less fluid running through the body, it's more likely that certain particles are going to accumulate because the urine's more concentrated. UTIs or urinary stasis is going to be a risk factor for kidney stone formation and any sort of sedentary occupation. So what does this patient look like? It varies depending on the client, but usually the hallmark symptoms are going to be pain, and it's a pain that moves. It's usually a sudden severe pain. So it's not going to be a minor pain. It's going to be usually something pretty painful. So they usually equate kidney stones, for especially when men have them, to like the only way they're ever going to be able to experience childbirth is through kidney stones. And they can have what's called renal colic, which is the worst possible pain. It's from dilation or spasms in the urinary tract. But yes, so pain, this is one of the few times where pain is a priority, which we'll talk about. They can have some sickness to their stomach. They can be sweaty. It's possible for them to have painful urination. It's all about that stone moving. So just think of like a literal stone, like a stone from like a rock going through your urinary system. It just hurts. It's scraping along the sides of that tract. So diagnostic testing, probably one of the most important tests we can do for these patients is retrieval and analysis of stones. Now, you may not think it's that helpful because, hey, just peeing them out, like it didn't help to get them, just collecting the stone probably doesn't seem that helpful, but it really is, because we need to know what kind of stone it is so they don't accumulate more stones. Once we know what kind of stone it is, we can get to the bottom of what their problem is. So hopefully they won't have more in the future. We can also do an ultrasound or CT scan. It's going to tell us where it is, but remember, it moves. So it only helps so far. And by the way, so to retrieve and analyze the stone, what we do is we strain all urine. So we have a strainer that we put in the toilet. We have to pour all of their urine through the strainer to catch any stones that might be there. We may look for other causes or other problems, like we might do a urinalysis to look for infection. We might look at a creatinine to see if your kidneys are functioning okay, and then maybe look at the fluids and electrolytes. Now, usually fluids and electrolytes are not that imbalanced unless they're having a lot of nausea, vomiting, unable to eat or drink for multiple days, having some issues there. But generally, this is the biggest issue here is just pain and making sure that they're getting good urine elimination, stuff like that. Best way to get rid of pain for these patients is going to be to get rid of the stone, because that's what's hurting them. So as strange as it seems, we do want to promote ambulation or promote movement of the stones, because just like with peristalsis, I have to be up and moving. Ambulation helps with movement of these stones. It can take up for a week for the stone to pass. These patients do not usually stay in the hospital up to a week. They might stay temporarily, but we usually try to send them home, and sometimes it just takes some time, but they'll still strain their urine at home. Some patients are going to need surgery, which we'll talk about some options here in a second. Here we go again, tamsulosin to the rescue. So sometimes this can help to ease the flow and allow for easier passage of those stones. And then pain management. And these patients are not going to be managed with, no Tylenol. They're going to get the opioids because this hurts like hell. So surgical options, they can do a cystoscopy where they go into the bladder. This is a cystoscope where they go in and remove the stone. There's lithotripsy, which I have pictures on the next slide. So they can place stents with these, but there's laser, shockwave, ultrasound, electrohydraulic things, but pretty much just think of it like we're going to try to target where the stone is and break it down, make it smaller so it'll be easier to pass. Whether we do it with a laser, shockwave, ultrasound, or electrohydraulic device does not really matter as much as the whole point here is lithotripsy. We are going in and trying to break down, get rid of the stone or make it smaller where it's easier to pass. And sometimes if stones are really bad, hold on one second, apparently I'm dying. Stones are really bad, we can do a percutaneous netherolithotomy where we go in through the kidneys and literally just take them out. Or maybe I'll show you a picture, it'll make more sense. So here's some of the lithotripsies and things like that. So they can use waves to break down the stones. They can use like ultrasonic pressure, where they're kind of pretty much, it's like a vibration where it's kind of like break down the stone itself. So this is a percutaneous netherolithotomy. So if there's really large kidney stones that get stuck, it's an ability to go in, they use a nephroscope and they can go in and I think there's a variety of options here. I think it depends. I think it's possible they can remove it with this device, or that if nothing else, they can break down, make it smaller, dislodge it in a way where it's going to be able to move forward and then stop causing an obstruction. Now, most kidney stones are not causing obstructions. They're just really painful, but it is always possible that they could. So overall, my goal is preventing complications, straighting all urine. I have to know the culprit to prevent this from happening over and over and over again. Prevent dehydration, but do not force fluids. So we definitely don't want to be pushing too much fluids. It can sometimes make things more uncomfortable. So with this patient, we do like fluids. We do not want them to get dehydrated, but we also don't want to overwhelm them as well. Oh, well, excuse me. We want to monitor their electrolytes, like I mentioned, too. So education, especially for prevention, because remember, to prevent this, we definitely want to avoid dehydration. So drink more water, and the more, this is all prevention. So like to prevent, if I'm going to be super active, if I live in Texas and I'm going to be running in the summer, I need to drink more water. So the more active they are, the more water they need. We also want to limit consumption of sodas, coffee, and tea, because those are a lot of the products that lead to formation of stones. And then dietary changes, less sodium. So this is something that students always find very confusing, but sodium and calcium work very closely. And so if I have an excess of sodium, it actually leads me to hold on to or reabsorb more calcium. So if I have less sodium, I'm not holding on to as much calcium. And so I know it's going to seem counterintuitive because most people think, oh, if I have a calcium oxalate stone, I need less calcium. But that can actually drive and cause worse issues because your bones start like getting rid of more and you end up accumulating more anyway. So I don't need a low calcium diet. I actually need a low sodium diet. And this can help to reduce the amount of calcium oxalate stones. So other things to avoid for calcium oxalate are going to be animal proteins, green leafy vegetables, and like I mentioned, sodium-rich foods. For purines, think gout diet. So avoiding organ meats and all those other fun things that we talked about when we talked about gout that we want to avoid so that we're not accumulating uric acid or making uric acid stones. All right, last but not least, benign prostatic hyperplasia, also known as BPH. This is something that just happens to men because only men have prostates. And so what happens is either with age or sometimes with hormonal or other changes, the prostate grows in size and creates an obstruction. So if you don't know where the prostate is located what do you call it? It surrounds, it kind of like hugs the urinary tract for men, near the top right before their bladder. But what can happen, like you can see here, like normally there's plenty of space for urine to flow, but as time goes on and their hormonal and age changes, things can get very narrow, and it's like a literal obstruction. So these patients, have a lot of difficulties with urination. I mentioned risk factors already, but age is probably the biggest one. Obesity, sedentary lifestyle, smoking and alcohol, erectile dysfunction, diabetes, family history, all can contribute. So my diagnostic tests, I need to rule out cancer and infection, because there's a lot of things that can happen if the prostate's enlarged. It could be a variety of things. So we do a CBC, a biopsy if for the physician and stuff like that. The doctors get to go in and feel the size of the prostate. The prostate is not something you can go in and feel through the urinary tract, so they get the pleasure of going up the butt, doing what's called a DRE, or digital rectal exam, because you can actually feel the prostate if it's enlarged through the like by putting your fingers up the patient's anus. So all those jokes that you see about like bend over and cough, like that's a real thing, and that's a digital rectal exam. Something to keep in mind. I'll go to it here in a second. So a lab test that we can do is what's called a PSA, or a prostate specific antigen. Now this is just going to be, kind of think of it like kind of like a troponin, where it tells you that there's damage or problem, but it doesn't, well, I would say it's more of like it's probably more like a CK. It's like a CK where it like tells you, hey, there's damage to some muscle somewhere, but it could be a lot of different causes. Like it doesn't really point to a cause. Someone could have an elevated PSA from riding a bike. Someone could have an elevated PSA because I just did a digital rectal exam on them. Someone could have, not that I'm doing it, the doctor. If they recently ejaculated, if they have an enlarged prostate, if they have inflammation of their prostate, if they have prostate cancer, all of these things elevate this. So it only is so helpful. So one thing is that if a doctor's going to do a DRE, we need to draw this blood first, because otherwise their exam could actually alter the state of their PSA. But then we also want to just evaluate for other risk factors. We also can look at the prostate. There's a transrectal ultrasound that allows us to visualize it as another option. So what does this patient look like? So compared to a patient with a UTI, so like we have kind of like kidney stones, it's painful, colicky pain. It comes and goes as that stone is moving. We have UTIs, which is that urgency frequency, where they're having a lot of painful urination and difficulty urinating. And then we have BPH. This is mostly a flow problem. So it's problems like everything with urination and flow is messed up. So what I think about is like the hallmarks for this is going to be things like intermittency, where they start their stream, but then it stops and they have to start again. They have general decreased or like a weaker flow, and then they have difficulty starting their stream, which is what's known as hesitancy, which we've talked about. They can have frequency. They can also more commonly urinate at night. They can have some pain with their urination or dribbling or incontinence, but I would say the hallmarks are that hesitancy, intermittency, and general decreased flow. So overall, I want them to be able to urinate adequately. So things I can do, there's medication. Here we go. Like I told you, there's tamsulosin again, your brother. And so he's coming to get you again for another urinary disorder and coming and helping. He's always there for you. And he could be a she too. I don't know why I'm gender stereotyping tamsulosin, but I'm just saying tamsulosin is going to be there for you. And so it helps by relaxing the smooth muscle. So tamsulosin in general for all the disorders is going to help to relax things to allow for better flow with urination. Cool. But the one bad thing is this is an alpha blocker. And it's either an alpha adrenergic agonist or an alpha blocker, one of the two. But it is a blood pressure medicine effectively. And so what you want to keep in mind is it can lower blood pressure. So the change position slowly, orthostatic hypotension, make sure to help them, safety reasons, preventing falls. So that's going to help with the actual like ease of urination. But we have to get to the bottom of the problem. If my prostate's enlarged, I need it to be smaller. So there's an actual medication that we can give to reduce the size of the prostate. And this is what's called finasteride. The downside of this is it can take months to see results. There is a risk of sexual dysfunction, which, I know a lot of times you guys are probably like, that's not going to be on our test question. It absolutely can be because, and I'm not saying it's going to be, so don't sit there and be studying sexual dysfunction all night long and say, well, Woodruff told me I need to study this. But what I mean is just keep in mind that like sexual dysfunction affects ability for a patient to have like general like day-to-day needs. And so it can affect their compliance with things, and take it very seriously because we can definitely give them counseling and other help or medications as needed. Other thing to know with finasteride is it is like kind of like a chemotherapy agent, or it's very teratogenic towards pregnant women. So it needs to be handled properly. Surgical options, we're going to talk about the TURP. It's the most common, where we can actually get that prostate smaller so there's more effective urination. And then we can also do something more radical like a prostatectomy and stuff if needed. So let's talk about TURP. So TURP is definitely a procedure, like we very rarely and so far in med-surg have had you go really in depth with a lot of surgical procedures. This is one you need to know in depth. I would want you to understand that it's an excision and cauterization to remove the prostate. So you can see what they're doing here. They're literally scraping away the tissue. I know this is probably very painful if you're a man to see this, or a woman, because I watched one of these procedures and I remember seeing the scraping and I was like, oh, this poor guy. But it's a very bloody procedure, because they're literally scraping away the tissue. But this is a staple. But like I mentioned, the biggest risk here is going to be bleeding. They also can have imbalances. We'll talk about this, but they get bladder irrigation afterward. And so what can happen is with that bladder irrigation, kind of like we talked about with enemas, where they can absorb too much of the fluid and get water intoxication. It's the same kind of thing here, where they can actually, we're trying to irrigate to keep them from bleeding and to flush out any clots that might be forming in their urinary tract as they're recovering. But what can happen is they can actually absorb too much of that fluid and they can end up in a state of hyponatremia. Hyponatremia is life-threatening and very dangerous. It's too much fluid, not enough salt. And what happens is they get really restless, irritable, confused. They can get brain swelling, and they can have very serious life and death complications. So we need to monitor closely. They may be on seizure precautions. We raise their sodium slowly. We also don't want to raise it too quickly because they can also have brain swelling if we raise it too quickly. And then they may be on a fluid restriction as well, because even though because they had too much fluid, not enough salt. And so if I give them too much fluid, it's just going to dilute even more. So by the way, if you're wondering, well, how do we raise their sodium? There is sodium tablets, but what we usually do is we give them fluid, but we give it at a slow rate. So like when I get people in the ICU that need this, they get like what's called 3% saline. It's really hypertonic, that gets at a really slow rate. So we're really trying to give them the sodium more than the water. Like I mentioned, some people might have to have something a little bit more radical. It's what's known as an open prostatectomy. And this is for men with more complicated cases. So because the other one, it's transurethral resection of the prostate, we can actually just go up the urethra. So it's like minimally invasive, whereas the open prostatectomy is very invasive. They do an external incision. They can view the entire prostate surrounding tissue, but we're cutting through tissue. We're cutting through nerves. So there's really high chance of erectile dysfunction. There's still a high chance of bleeding, more pain, and a higher infection risk because I'm cutting into the tissue. I'm leaving a open port for infection to get in. And I know it's not open, but you know what I mean. So post-operative, I'm managing complication. Like I mentioned, hemorrhage, bladder spasm is common. So the patient might get some antispasmodic medications. Incontinence can happen. Infection can happen. This patient's usually going to be maintained with a catheter for a while. They're going to go home with it most likely. So they need to know how to care for it and how to prevent infection at home. We'll talk about bladder irrigation management on the next slide, but it's my job as the nurse to manage the bladder irrigation. I do not want this patient straining. Anything that's going to cause excess pressure could lead to bleeding. And I'm going to monitor their intake and output closely. So bladder irrigation. So I talked about that three-way catheter near the beginning, and I talked about how the whole point of the three-way catheter is to allow for irrigation. So what happens is I have these really big bags. They're usually like, I mean, they're sometimes like 3-liter bags. And what they're doing is they're continually, think of like how you flush your patient's IV to make sure it's patent. This is like flushing the bladder, because what can happen, like I said, it's such a, especially if this is the TURP, we're talking about the TURP here, not the open prostatectomy usually with this, but I don't think they use bladder irrigation for open prostatectomy. It's mainly just the TURP that I know of, but I promise we're not going to quiz you that deep about that. But just know after the TURP, we 100% are going to have this continuous bladder irrigation, lots of fluid flushing things out, because there's all that bleeding, and they're also more likely to form, like, because of that bleeding, like stuff's going to maybe clot off. So we definitely we want to keep a patent Foley catheter. My purpose of my bladder irrigation for this patient is to clear out any excess blood and promote good urinary output. I need to always assess the patency of my catheter. The big thing I'm going to need to assess is the color of the urine. And so pretty much blood clots can be expected for the first 24 to 36 hours, but after that, it's not considered to be normal. If there's bright red blood, that's a concern for hemorrhage. Like the color that should be coming out, it should either be a normal color or it might be pink tinged. And, a little bit of pink in it is okay. What do you call it? But again, after 24 to 36 hours, there should be no clots in it, no matter what. I need to regularly empty the Foley catheter. These are 3-liter bags. They flush this catheter pretty quickly. So like you usually have large buckets and you have to like empty every few hours. So normally like your techs help on the floor with this kind of stuff. This is one of those times where it's not I'm not saying they can't help, but they might have to be on top of it more often. Or a lot of times us as nurses, we just end up doing it because I have to monitor really closely. I want to make sure whatever's going in is coming back out. Because if there's a discrepancy, they might be getting that water intoxication or getting that TURP syndrome. Give antispasmodics as needed. But here, I want to tell you one clarification, though, in this is that if a patient is having sudden intense spasms, like I'm not going to just be like, oh, well, let me just go get your, antispasmodic. I might need to give that to them. But first, I want to check for obstruction, because if they're having sudden intense spasms, it can be a sign that their Foley catheter has clotted off and they're feeling that spasms because there's an obstruction. So I want to check and make sure everything's unkinked and that there's no sign of obstruction, that they're still getting output. But as a whole, like I mentioned, we're just watching for the color. We're looking for clots. We're making sure that the color stays consistent. I'm making sure everything stays patent, and watching those I's and O's super closely. Overall BPH education, those Kegels, like I said, they're not just for women, can definitely help to keep a very strong sphincter for these men. Preventing complication, again, same thing, like where it's putting pressure on the urinary tract, which can lead to more obstruction. We want to avoid the alcohol, caffeine, citrus juices, all the good stuff, chocolate, spicy foods. We like them to urinate every few hours to try to empty, because remember, this is like BPH is like having chronic urinary retention, where they're always kind of holding on. They have trouble emptying because they have flow issues. So we want them to urinate regularly, good water intake, like they're just like a patient with urinary retention, because they are a patient with urinary retention. We like them to spread things throughout the day so that their bladder does not get overwhelmed. All right, speaking of being overwhelmed, I hope you're not too overwhelmed right now by urinary disorders. I had a lot of fun teaching you. Have a great day.